Dr. O.Domenig received his doctorate in endocrinology and metabolism from the Medical University of Vienna, and his dissertation was in collaboration with Adequant Diagnostics, the company he's currently affiliated with. And he focused on the development of liquid chromatography mass spectrometry-based analytical methods to quantify peptide hormones in tissue samples. And so since finishing his doctorate, he's been working with Adequant Diagnostics as the head of their laboratory, developing assays and supporting research groups and pharmaceutical companies and veterinarians like us all over the world, and advancing proprietary technologies that investigate and help us better understand the renin-angiotensin-aldosterone system. So without further ado, I would like to welcome Dr. O.Domenig.
So hello, thank you very much for the very kind introduction. I would like to I hope you can see my screen right now. Hello?
Yes.
Yes, okay, that's great. So thank you very much for this very kind introduction. So today I would like to talk about the molecular insights in the renin-angiotensin. So my name is O.Domenig and I'm working for the Adequant Diagnostics. First of all, I would like to introduce a little bit the company I'm working with. So our service is the LC-MS/MS-based peptide quantifications at premium lab quality. So we have 10 years experience in the biochemical characterization of the Renin-Angiotensin system, and we contributed to more than 70 publications in peer-reviewed journals. So currently we have a clinical LC-MS/MS-based assay in the daily routine to diagnose molecular causes of resistant hypertension. This assay is currently offered only in Austria, but we want to roll it out to the further EU in the next years. And we are currently involved in 3 clinical trials in the phase 1 and the phase 2 trials. So, but let's talk about the molecular players of the renin-angiotensin-aldosterone. You have already seen this slide on Marissa's page, and you see it. This is the RAS. And first of all, as we all know here, the whole RAS is started with angiotensinogen, AGT. Angiotensinogen is a big protein. It is derived from the liver in a vast molar excess. And then there's renin, which is here. And renin is an enzyme derived from the kidney, and it cleaves off Ang1. Ang1 is a decapeptide. And Ang1 is inert. It has no biological activity, as we know so far. But Ang1 is cleaved by ACE. ACE could be here attached on the endothelial, or it can be in the plasma or in the blood. And Ang1 is cleaved by ACE to Ang2, and Ang2 is the main driver of the RAS. Angiotensin 2 interacts with the AT1 receptor. AT1 receptor activity leads to vasoconstriction, water and sodium reabsorption, vascular permeability, hypertrophy, and RAS production. But Ang2 is also cleaved by other enzymes, for example, by aminopeptidases or ACE2, as we know. And ACE2 cleaves Ang2 to Ang17. And Ang17 is the good guy in the whole system. So Ang17 interacts with the MAS receptor, which has opposing effects. It leads to vasodilation, diuresis, anti-inflammation, anti-proliferation, and so on. And there are several other angiotensins, and we don't know for all of them their biological activity, if there is any or not. This is something we will find out in the future, hopefully. But what are the challenges in the bioanalytical, from the bioanalytical perspective? So the first problem is that the angiotensin levels are in the lower picomolar range. So this is an issue for the sensitivity. And we have high sequence similarities between the metabolites and an excess of the prohormone, the angiotensinogen, which is 100,000-fold higher in the samples. So we have an issue with the specificity. So you have here all the angiotensins. This is angiotensin 1, 210, Ang2, and so on. So they are very, they share very high sequence similarities. And we have the problem with the matrix because those angiotensins, they are in blood or in tissues and so on. So we have the sample complexity is the problem. There are lots of lipids, proteins, sugars, and they all affect the quantification. And last but not least, we have a rapid enzymatic formation and degradation of the angiotensin peptide. That means if you draw blood, you have a constant formation and degradation of the angiotensins in the blood post-sampling that leads to sampling artifacts. So in order to address the sensitivity and specificity problems, we invented an LCM-SMS-based quantification of angiotensin and of aldosterone, and we use for them internal standards. So internal standards, they are isotope labeled or deuterated. That means they are of the analyte. That means you have the analyte, for example, this is the internal standard of Ang2. And the internal standard is completely the same as the analyte you want to measure, but only one amino acid is heavier. And that means the physiochemical properties are completely the same. The only thing, it is a little bit heavier. And this internal standard we add at the very beginning here to the blood. Then we extract the blood with solid phase extraction here, and it's cleaner. And we use UPLC, that's ultra pressure liquid chromatography. And then we measure it with mass spec. And mass spec allows a very precise decombination between the different angiotensins, but also between the angiotensin 2 here, for example, and the internal standard. That means the stable isotope labeled angiotensin metabolites or the deuterated aldosterone for the internal standardization is the gold standard in analytics. And the simultaneous and highly specific detection of up to 10 angiotensin metabolites and aldosterone and the corresponding internal standards in a single samples of 0.5 ml of plasma or serum. So this is what we do. And in the end, we get the levels of 10 angiotensins, for example, here of Ang1 and Ang2 and Ang3 and Ang4 and so on. And we gather the information here in a so-called fingerprint. We will see them, this kind of diagram later on. That's why I wanted to explain it here a little bit. This is a RAS fingerprint. And for example, you have here Ang1, the initial angiotensin. And Ang1 is cleaved, for example, by ACE or ACE2 or aminopeptidases, resulting in Ang2. And the diameter of the sphere here reflects the actual concentration. Please keep that in mind. So, and the blue arrows here, they indicate a possible enzymatic activity. This is the RAS fingerprint. But we can also combine the peptide levels with aldosterone. So the RAS fingerprint looks like this. So you have Ang1 and Ang2, and the Ang2 interacts with the AT1 receptor, and AT1 receptor signaling results in the release of aldosterone. So let's talk about the stoichiometry of the human plasma RAS components. So as I said before, we have angiotensinogen in a vast molar excess between 10 to 100 microgram per ml. That means 200 to 2 million picomolar. And you have renin. The renin concentration is low. That means the substrate concentration is much, much higher than the enzyme concentration, which results in a classical enzyme activity. So for this reaction, angiotensinogen to Ang1, only the concentration of the renin is important. But the Ang1 here has a concentration between 0 and 500 picomolar, and the ACE concentration from the enzyme is higher. That means this is the opposite. This is no classical enzyme reactivity, because the substrate concentration is lower than the enzyme concentration here. That means with the plasma renin activity from 100 to 200,000 picomolar Ang1 to hour leads to a highly dynamic cascade. So, and you have a complete exchange of the angiotensins here every 2 to 3 minutes. That means the angiotensin right now is gone in 5 minutes, but it's also converted, it's also formed again by renin. And when we can, and while the angiotensinogen concentration does not change significantly. So we can use this unique enzymatic composition here to make an equilibration of RAS metabolism. So what we do here, so we take the plasma or the serum and we incubate it for several minutes or hours at 37 degrees. And you see here at 0, this is the concentration of Ang1. After 15 minutes, you have an increase of Ang1, but suddenly it's stable. Also for this serum pool with a higher renin activity and also for this. And the same is true for the metabolite of Ang2. After 1 hour, it's stable, does not change anymore. Why is that? Because you have a constant formation of Ang1 in the plasma at 37 degrees ex vivo, but you also have a degradation. And after 1 hour, you reach an equilibration state. And this stadium only depends on the enzymes which are present in the sample. So using this technique, you get an idea, or you know the enzymatic composition of the plasma. This kind of analysis we call equilibrium analysis. So we can use standard serum or heteronized plasma. The bench stability is 8 hours, and you can also use bank samples for older than 5 years. And those levels, they reflect the enzymatic composition of the plasma serum. And it depends on the enzymatic activity under physiological conditions in undiluted plasma, under physiological substrate concentrations, and with the physiological cofactors. Earlier days, we used to stabilize the blood samples immediately after samples. For this, we used an inhibitor cocktail. This kind of analysis allows to measure circulating levels. It requires the immediate and complete stabilization is essential during the sampling. So you need a rapid mixing with the inhibitor cocktail, be kept on ice post-sampling, and an inappropriate handling leads to artifacts. And what we measure actually is the angiotensin levels remaining in the circulation after endothelial uptake or conversion. So how do they correlate to each other? We checked that in a paper years ago. We measured the circulating angiotensin levels. So these are the levels immediately stabilized, and the equilibrium angiotensin levels in patients treated with an ACE inhibitor, with an angiotensin receptor blocker, or with an ARNI, that's an angiotensin receptor blocker plus an aprilicin inhibitor. And you get here the RAS fingerprints for the circulating angiotensin levels and the equilibrium angiotensin levels. And you see, you get the same picture. So they also correlate to each other, those levels. That means although those levels are higher, the qualitative outcome is the same. So, and these are typical RAS fingerprints. For example, you have the control here and the patient treated with an ACE inhibitor, and these patients were treated with an ACE2. See here, typical shifts. Control is the ACE inhibitor blocks the ACE activity, which leads to an accumulation of Ang1 and an accumulation of Ang7. And here you have the ACE2 and shifting the RAS to the alternative side, to Ang7 and 5, because ACE2 is here. But this is nice to see, but how can we extract more information? How can we compare it? And for them, we played a little bit with biomarkers, and we found that they correlate with enzyme activities. For example, when we calculate the sum, the Ang2 plus Ang1, we call the biomarker for the renin activity, PRAS it's called. And if we calculate Ang2 divided by Ang1, we get a biomarker for the ACE activity. We call it the ACE-S. And there is also another biomarker. We call it the ALT-S because it's a marker for the activation of the alternative RAS, which is the sum of Ang1 and Ang7 and Ang5 here divided by the renin activity. I will show you all of them biomarkers on the next slides. For example, the PRAS. This is an angiotensin-based biomarker for the renin activity. So we had here a study last year where we have patients with resistant hypertension and normal hypertension. That means those patients were very low renin, very high renin. And we see a very nice correlation between the PRAS, which is based on our angiotensins, and the clinically measured plasma renin activity. This was done in Italy. So very nice correlation. So I don't say that the PRAS is the renin activity, it just correlates with the PRA. It helps to interpret the patterns. Same is true for the ACE-S. So the ACE-S, but before, this is a biomarker for the ACE activity or the inhibition. So for this study, we measured perindoprelate, which is an ACE inhibitor in patients taking the perindoprelate baseline 4 hours later or 24 hours later. And you see here, this is the classical ACE activity assay, and hardly a correlation. And this is our assay. So this is the ACE-S and the perindoprelate concentration. And the higher the perindoprelate concentration, the lower the ASS. Also simply a correlation. It's quite nice. And this one is the Alt-S. This was a little bit tricky to find it out because let's say that last year there was a case report. A company also based in Vienna, they treated severe COVID-19 patients with soluble ACE2 for twice daily for 7 days. And you see here that angiotensin 2, Ang1/7, and so on. This is the treatment. So after the first treatment, Ang2 goes down, which is obvious because ACE2 cleaves Ang2. But then we got those profiles, and then we measured ACE2 itself. The ACE2, of course, goes up here, and then we played a little bit with the markers. And in the end, we found out if we sum up Ang1/7, Ang1/5, and Ang1/9, all of them are products too. And divided by Renin, we get a very nice correlation between this marker and the ACE2 activity. So, yeah. So these are the markers. And on the next few slides, I would like to talk about some publications we were involved in. For example, this is a paper of Marco Yama that deals with the effects of angiotensin receptor blockers and angiotensin converting enzyme 2 on the plasma equilibrium angiotensin peptide concentrations in dogs with heart disease. And this is the RAS fingerprint in dogs treated with an ACE inhibitor and an ARB. And you see this typical pattern. So it means ACE is blocked, same as ACE converts Ang1 to Ang2 and Ang1/7 to Ang1/5. Those substrates are stabilized and they accumulate. But you have a decrease of Ang2, which triggers the renin secretion. That means you have an increased flow in the system here. That means that results to increase Ang1/7 levels. Here the same is true with an ARB. The ARB prevents the binding of the Ang2 to the AT1 receptor, which also triggers renin. It means you have an increase of Ang1 and Ang2, but there's so much ACE2 in the plasma of dogs that you have an increase of Ang1/7. And this even more pronounced, the production of Ang1/7 than with an ACE inhibitor. And if you treat those dogs with an ACE2, you get this profile. It means you have the stabilization here and then accumulation of Ang1, but Ang1 is converted by recombinant human ACE2 to Ang1/9. And Ang1/9 is also cleaved by ACE. That means you have a partial accumulation of Ang1/9 that leads to this pattern. Same is true with the ARB. You get this picture here. So in conclusion, we can say that the ACE inhibitor and the ARB treatment result in an increased angiotensin level, all of them, because the lowered Ang2 signaling triggers the renin activity. That means the PRAS goes up, and the ACE inhibitor prevents Ang2 and Ang1/5 formation, stabilizes Ang1/7 and AT1. That means the ASS goes down. And the alternative ACE ratio, it goes up in dogs treated with an ARB. This is more pronounced than in dogs treated with an ACE inhibitor. The reason is because the ACE2 has an affinity to the AT2 and not to AT1. So ACE2 preferably cleaves Ang2 and not Ang1. That's the reason for this. This is in contrast to the human situation, because in humans, it's the opposite. This is a paper in heart failure patients with preserved ejection fraction, and these heart failure patients with no RAS, with the ACE inhibitor, and you can see here, this is the same pattern as we have seen in dogs, but the difference is in humans you have a higher Ang1/7 levels, because in humans the neprilysin pathway, Ang1 to Ang1/7 via neprilysin, is more pronounced, and in dogs the ACE2 is more important. That's what we see here. So this is a little bit, both have the same effects, and so ACE inhibitors and ARBs have the same effects in dogs and humans, but we can see differences in the RAS profile. So that means we have species-specific differences. So let's talk about another paper from Darcy, which is very, very interesting because she treated dogs with with gene polymorphism in ACE with enalapril. We have seen this is the negative, so no polymorphism, and positive with ACE polymorphism. So we treat it with an ACE inhibitor. Here we get the same picture. Again, what we already know. But the interesting thing here is that aldosterone levels, they increase. Why is that? Because if you look at the profile, you see that enalapril does what it should do. It inhibits ACE. It leads to an accumulation of Ang1 and the decrease of Ang2 levels, but you still have increased aldosterone levels. And this increase is more pronounced in positive dogs, ACE polymorphism positive dogs, as you can see here. So as a conclusion from this paper, we can say we have no differences of RAS levels prior to enalapril treatment, and enalapril suppressed Ang2 formation in both groups effectively, so that's fine. But we have an aldosterone breakthrough, negative and positive dogs. That means although enalapril is effective, we still have increased levels of aldosterone. And this finding support the use of aldosterone receptor antagonist in combination with ACE inhibitors, because an ACE inhibitor itself is not enough. So this is another paper I would like to talk about. This has nothing to do with human and dogs. I just want to show you that the RAS profile is sometimes very complex and good for new findings. And what we found here is we measured in mice, in DPP3 knockout mice, the RAS profile, DPP3, dipeptidyl peptidase 3. This is an enzyme known to convert Ang2. No, now we know it. So you have here the RAS profile. And what you see here in DPP knockouts, DPP3 knockouts, you have increased levels of Ang2 and all metabolites of Ang2. But the increase is not that pronounced in Ang1. So you also have increased levels of serum aldosterone because of the higher Ang2 levels. This was really new. So now we know DPP3 is an important player in the RAS, acting on the degradation of Ang2. So and the physiological role of DPP3 is so if the knockout of DPP3 triggers stress, as you see here, the ROS generation, the lipid peroxidation, and catalase activity increases, all of them. So this means less Ang2 degradation result altered RAS profile and then enhanced ROS generation and catalase activity. So what I want to say here is this finding encouraged the company to develop an inhibitor for DPP3. Why? Because under specific circumstances, for example, under septic shock, we need Ang2 desperately. And this company, they developed now an inhibitor for DPP3 to increase the levels of Ang2, which is really the opposite to all what we usually do, because usually we want to decrease Ang2 levels, but under septic shock, it's important to increase the levels. And this paper was the kicker for the company to develop a DPP3 inhibitor. And last but not least, I would like to talk about COVID-19, of course, because it's everywhere. But we did ACE2 measurements in severe and non-severe COVID-19 patients. And what I wanted to show here is that in severe COVID-19 patients, ACE2 increases. There's really a surge of ACE2. So, and it's a biomarker of the outcome and treatment response. So what we have seen is on the ICU, patients with high ACE2 is a marker for a bad outcome. But if it goes down again, good for the patients. If not, it's a bad sign. So what I wanted to show here with this paper is that the RAS is also affected by not only by hypertension, but also by infection diseases. So as a conclusion, the multiplex role RAS profiling provides comprehensive overview of a complex network of peptides and enzymes. Biomarkers here support the interpretation of the RAS profile. But we always have to keep in mind that there are species-specific differences between dogs and humans. And the aldosterone breakthrough is more common in dogs than in humans. the enzymatic activities within this enigmatic RAS network is not fully resolved, as we have seen with DPP3. And the enzymatic composition in the plasma, or the enzymatic activity may be altered following viral infection, as we have seen for SARS-CoV-2. So yes, this was my presentation. So, thank you very much.
Thank you. That was an absolutely enlightening presentation, and I think it illustrates to all of us why it is so difficult to quantify the RAS in the first place in these minuscule concentrations and extremely related family tree of peptides. That really helps us understand that. And also that it's not just quantifying the peptides, it's also finding a way to better understand the enzymes, as simply as possible without having to create multiple different assays to look at enzyme activity. And then what do we do with that data? So I think it's really telling that it's taking an entire company with multiple bright minds to better understand how to assay this in hopes that this can become more broadly available. So really fascinating. I think as questions start coming in, I'll start with one, and that would be what the increasing ACE2 levels in circulation. So A, is that in any way negative? And B, what is it implying as to what is happening in the tissues, or what is the cause of increased circulating ACE2?
You mean in SARS-CoV-2, for example?
In like COVID-19, we have,
yeah.
Or
so we don't
I should
know.
say
We don't know yet. So there are two hypotheses. One of them is that this is a rescue marker. That the physiology says, okay, there is a viral infection and we want to increase the ACE2 activity to support intron 7 generation. And the other hypothesis is that it's simply an accident because ACE2 is in the lung. There's a lot of ACE2 in the lung. And as we know, is in COVID-19 patients, the lungs are destroyed. And that means that the ACE2, which is on the endothelials of the lungs, this is destroyed. This is just a crash. We don't know. So yeah, we wanted to find it out. There is a company in Austria, they tried to treat patients with ACE2, COVID-19 patients on the ICU. And there was a phase 2 trial. And the outcome was, it was not that simple. So in the first place, this the initial idea was that SARS-CoV-2 decreases the ACE2 activity, and they wanted to supplement it, but it's not that simple. So I think they did not reach the primary endpoint, but they get some interesting findings in this study that under specific circumstances, the treatment with ACE2 is helpful for COVID-19 patients.
In the case of a patient without lung disease, so maybe myocardial disease, and obviously that can affect the lung if there's heart failure, but if their primary disease is myocardial disease, if ACE2, in some recent studies, ACE2 increases in people with chronic cardiovascular and kidney disease without lung disease, is that telling us anything about what is happening in the tissue with, say, cleavage of ACE2?
Yeah, we want to find it out right now. So we don't know yet, sorry. Mm-hmm. But what we do right now is we measure the ACE2 activity in plasma and in lungs simultaneously from people from the ICU and not on the ICU. And we wanted to see if there's a correlation or not. So we don't know, but I think publications are coming along.
Excellent, excellent. Well, in terms of just sticking with this idea of tissue RAS, I think a lot of us have trouble grasping the concept of the tissue RAS and how it is related to the circulating RAS. What are the current theories as to the generation of angiotensins in the tissues? Is it locally derived from precursors in the tissue, or is it coming from the circulation?
Yes, this is also not so easy to. This is not so easy to address this question because we don't know. Or I think there was the hypothesis that there is an independent local RAS with its own angiotensinogen and renin and ACE and so on, and then a local and independent generation of all the angiotensins. But that's not what we see when we measure angiotensins, for example, in rats or in mice, where we can measure the angiotensins in the tissue and in the plasma. That what we see there always is a nice correlation. So what we think is that the angiotensins, especially Ang1, goes from the blood, goes into the tissue and is hurt there by the microenvironment. For example, in the kidney, there's a lot of neprilysin, or the heart, there's more ACE and so on. So that's so we think there is a close connection between the blood and the tissue.
Excellent. I think we're showing that there's a lot of security in your industry since there's still a lot to be understood. We have a question from the audience from Alice Watson. She's wondering if blood samples can only be reliably analyzed if they were collected on ice with the inhibitor cocktail.
It depends on the inhibitor cocktail, of course, because there are several inhibitor cocktails on the market. But the problem is that you have the enzymes which are acting on the angiotensins. They are very, very diverse. You have one which is a non-metalloprotease, and EDTA, which is a metalloprotease, and so on. And you have to be sure that the cocktail covers all of them immediately and effectively. So yeah, it depends on the cocktail in the end.
And so if
That's what I can say. And ice alone is not good. Ice alone is too less because the plasma or the blood cools down. If you place it on ice, it cools down. But you have the for example, the aminopeptidases, they can work also at lower temperatures other than renin. Renin stops work while the aminopeptidases are still working for the time the blood cools down. So you have a bias because one of the enzymes is working and the other is not. So this is a problem.
And for clinicians that are running around on the clinic very busy and we can't do the protease inhibitor, do you mind just re-explaining the analysis from just a plain untreated serum sample and how that correlates to a protease inhibited sample? So I think she's asking what happens if we don't protease inhibit and carefully handle the sample.
Yeah, so for our kind of analysis, using heparin plasma or serum is fine. So the best way for doing that is to keep it at room temperature, plasma or serum, just to keep it at room temperature and then freeze it immediately on -20 or -80. Don't place it on ice, a plasma or a serum sample, because then it might activate the prorenin. This is, which is an enzyme which is not active in plasma, but under ice or on ice, it can start working. It cleaves angiotensinogen to Ang1. So that means you have immediately a big angiotensin 1 formation on ice. But this is a little bit confusing, I know, sorry. But I was also very confused in the first place because I'm a biochemist and we used to place plasma and protein solutions on ice. But working on the RAS, it's not a good idea because of the prorenin. So it's better to keep it at room temperature and freeze it immediately.
Yes, well, it's been the ability to do the equilibrium analysis, sounds kind of funny, but the ability to do that on a standard handled serum sample has been really helpful for clinicians. And so I think the good news for Alice and everyone out there is, we've had great experience working with Adequant. We can contact them about specific sample handling techniques and make sure that we're handling everything appropriately to get the most accurate analysis. So that is an excellent question. Great. Well, if anyone else has any questions, you are welcome to use the chat feature. If not, I will continue to ask one more question, which is how, as especially veterinarians, or this probably impacts human healthcare workers as well, we can't always get tissues removed at post-mortem. And so how, in terms of measuring the tissue renin-angiotensin-aldosterone system, how do you recommend that we handle tissue samples that cannot be removed from the body post-mortem very quickly, and how would you analyze the RAS in those patients?
So the problem with the angiotensins is that they are very volatile, as explained before. So that means in tissue, for example, if you extract a kidney or a heart, it has you have an ongoing enzymatic activity acting on the angiotensins, and they bias the angiotensin levels, of course. So that means what we do in our companies, we analyze angiotensin levels in the tissue only in mice and rats, because we can extract it easily, and then they put the kidney, for example, small kidney or the heart, in liquid nitrogen. Then everything is stable, because under liquid nitrogen, there is no enzymatic activity anymore. For example, for bigger tissues, which is not possible to place in liquid nitrogen, for example, from dogs or from humans and so on, it's from our side, we don't see a possibility to measure endogenous angiotensin levels. But what we can do is we can measure enzyme activities, but because we know that the enzymes, they are still active for a longer period of time, also on room temperature. That means we can still analyze ACE2 activity, ACE activity, abrylacin activity in tissues derived from biopsies from humans, from dogs, and so on. So that's possible, but unfortunately, it's not possible to measure endogenous angiotensin levels.
Excellent, but we at least can look at the potential of their enzymes, which I think is still very interesting.
Yeah. So
we have another. Oh, I apologize. We have another question coming in from the UK. Do all species have the cold activated enzyme? We have found no evidence of this in the cat. I think when you were mentioning prorenin.
Oh, great. That's a great question. To be honest, I don't know. So what we know is we have this prorenin activity, and it is described by other groups in humans. This is what we know, and also in mice. But I don't know if this is true for cats. I really don't know. I want to figure it out in the next month in a collaboration with a partner, where we wanted to investigate the influence of free thaw cycles on cat plasma. But I don't know yet. I'm sorry. But yeah. But it's a very, very good question. Thank you very much.
That is an excellent question. Do you mind for the audience defining prorenin? I think a lot of people may not know prorenin and the prorenin receptor.
Yeah. So actually, it's an enzyme. There is an enzyme which is capable to change one, cleaving angiotensin. But usually there is a hand, I think, over the active site of the enzyme. And under the cold conditions, there is a defolding of the hand, and suddenly the active site of the enzyme is available to angiotensinogen. And this hand is deferred by cold. That's what we know. This is described. So I think it's also possible to open up the hand with acid, I think, on a pH level 4 or 3. Yeah, the problem is the cold. So, for example, I only know it for Austria, for the medical university. It's not allowed to place plasma on ice if you want to measure the plasma renin activity because of this reason.
Excellent. Very helpful.